My name is George Hripcsak. I'm chair of biomedical informatics at Columbia University and New York Presbyterian Hospital. And I'm going to be talking about next generation electronic health records to facilitate oncology care. I have nothing to disclose and there's no unlabeled uses. So to start, I just want to kind of get the current status. First, from a research point of view, NCI recently contracted us to look at how EHRs can be used today, say to support research in the sense of, is the information there? And in fact, we found that we could do better than you might think in cancer, identifying cancer or type of cancer. We had a specificity of 99.9%, sensitivities over 90%. To identify what treatment you got, we again had high specificities and slightly lower, but still usable sensitivities. And so then we carried out studies. For example, one question was, do patients with chronic disease get treated similarly whether or not they have cancer? And we found that, in fact, the treatment pathways are the same for patients with and without cancer. So there is information there. That's from the researcher's point of view. From the doctor's point of view, well, first, before we knock electronic health records, I want to point out that health records are much better than paper, especially for complicated diseases like cancer. But we do recognize the documentation burden. Even a decade ago, the American Medical Informatics Association policy meeting identified this problem. And a lot of the problem was thought to be due to multiple uses of health records in addition to clinical care, such as billing and litigation. When we look at cancer care, which is very intricate and complex, that adds to the documentation burden, and can we really get that information? So even today, before I get to the future, we're working on improving this. The AMIA 25x5 initiative to reduce documentation burden by 75% in 5 years is working on that. One interesting finding from that is not just about billing, that countries around the world are grappling with documentation burden in electronic health records. So there are multiple factors, and we should all work on this together. The Observational Health Data Sciences and Informatics, or Odyssey initiative, it's an international observational initiative, open science, with 2,000 members from 74 countries, has an oncology work group. And it's looking at the complexity of cancer progression and how to represent that in electronic health record. That is, the progression to disease, getting to metastatic disease, and the complexity of storing the different cancer protocols, not just the individual components, but what protocol are you on and how do you deviate from that? Third, both patients and doctors need to review the information, and we're using data science to improve that. This is an example of parsing an entire record worth of notes, putting in a word cloud so that you can see what's going on with this patient rather quickly to see how the patient's status is. Nevertheless, despite all this work, I think the future of EHRs could be very large. We've not really reached the tipping point in health records. If you look in the 1970s, the health records, the best records from then, don't look too different from the ones from today. Pictured here is the Apple Newton. Some of you will remember it was an interesting device, didn't really work until the Palm Pilot, not shown, but the Palm Pilot came out, and it changed everything with a major usability breakthrough, being smaller and more usable to more people. And I think the health record is on the cusp of that kind of an advancement. In oncology in particular, first of all, by being more patient-focused, we can ask questions, can we help patients handle the more toxic therapies that are in oncology? Because we want to intervene while there's a chance early in these, say, side effects from these treatments. On the other hand, if we're looking at the future of electronic health records, we can also look at the future of oncology, hoping that targeted therapy becomes less target, and maybe we'll shift more electronic health records to cancer prevention. And when I see this shift, becoming more person focused, first, if what we mean by electronic health records in the future is just the hospital record and a record of doctor's office visits, it'll become increasingly less important to patients because there's going to be a shift to this bigger thing, the life record. And so I'm really going to use electronic health record as this new evolution that has mobile computing, physiologic monitoring, social media, and so on. And not just to store information, but to inform patients and doctors, to advise, and to educate. So what I kind of see is that there'll be some genomic baseline that is measured for everybody, periodic sampling and imaging, and ongoing monitoring. We already have people working on the technology so that you can optically do an ongoing Chem7 on a person just through their skin. And while we have these, health watch sensors, They can also turn outward. They could be looking for carcinogens, allergens, microbes. Your smoke detector may be on your wrist. And looking at meals, I'll get to that in a moment. One point I wanted to make on a couple slides on what we've learned so far. First, we need to engage patients. Well, one thing we found, for example, we think that patients come in for inpatient treatment, say for cancer surgery, they're the most isolated patients. They're the ones who need to be engaged. And we did experiments showing that we can improve patient status by engaging them there. Can patients handle this technology? 20 years ago, we gave patients who never had access to a computer or even a bank ATM, and they were doing home pulmonary function tests, full FEV1, not peak flow. And by this curve, you can see how exactly it matches. Exactly match the laboratory test. So patients are capable of doing it, but we need to support those patients who cannot. And we need to make sure that we don't have a division between those who can do it and those who cannot. As we collect all these data, we're going to have a lot of information flying in, a lot of deviations in blood pressure, glucose, and so on. We can't send everyone for appointments, and we can't alert doctors or patients all day long. So I think the evolution will be for an importance of data science and human-computer interaction. On the top left there is a data simulation thing that predicts, system that predicts glucose based on meals and that individual patient's physiology. That's person-specific physiology. But even when we get these good glucose measurements and with a smartphone, say we can, based on a meal that we take a picture of, we can actually tell you your glucose in 2 hours. Having that prediction, what does the patient do with that? So a lot of this is about the human-computer interaction on the right side of the screen, showing that we need to understand how to interact with patients, how to motivate them to make changes, and then we can build systems shown on the bottom left. That's the browser screen, but it's actually used on the smartphone, a simpler application, which we did show in a trial could improve their glucose. And then just circling back to finish, to research, if we build this better electronic health record that supports oncology, we want this learning health system with this circle shown on the upper left of precision medicine. The diagram on the lower right shows that we want this to be a combined system, that our research and our clinical care and patient focus are combined into one mission. Thank you.